The patient is a 41-year-old male, and his risk factor includes smoking and hypertension. The patient was admitted to hospital for chief Kaplan as unstable angina pectoris. And the patient's lab examination during the hospitalization shows it has a normal eject fraction, but had a little bit of change in his EKG, has SCT change. Okay, next. About 2 weeks ago, he has performed the right coronary artery do the PCI for his right coronary artery, put 2 stents in his right coronary artery, and then about 1 week ago, we do the second time PCI for his left anterior descending. Today we focused on the lesion at the left circumflex, but it's very interesting because as we show in the picture, we can see here is the true bifurcation lesion in the proximal lesion of the circ, but still we can see there's a CTO lesion is distal circ. Fortunately, we Dr. Ye successfully canalized the CTO lesion, and we found we have 2 bifurcation lesions. So okay, it's your turn now.
So could you calculate the risk stratification of this case before procedure? So after performing successful PCI for RCA and the LAD, so today we will focus on the circumflex lesion combined with OM1 circumflex bifurcation lesion, 2 bifurcation lesion with a medulla 111, and distal circumflex also maybe also bifurcation lesion. We cannot see it clearly just because there is a subtotal occlusion.
Okay. We have calculated the syntax score before PCI for the patient has a his syntax score was 16. It seems to be a lower risk.
Yes.
And his syntax score shows the PCI 4-year mortality was 4.2%, and his KBG was 1.3. As we mentioned, today we are focused on the circ and the obtuse marginal bifurcation lesion. We determined to use the intracoronary image by IVUS to perform this PCI. Okay, thank you. That's all.
So we can see this is a very challenging case combined with a bifurcation lesion and subtotal occlusion, maybe a total occlusion. So Professor Zhang, could you give me some recommendation for this case?
Yeah, actually, it's a very challenging case. Although this patient is quite younger,
yes.
Considering the target is circumflex lesion. Actually, it's 2 lesions. One is a distal CTO lesions. Another is a very important challenge, difficult to access circumflex and OM. Before we treated the OM, I think we should successfully open the distal circumflex. So, Dr. Ye, what's your strategy for this distal circumflex?
Yes, for me, it's a challenge. If we want to perform a PCI for distal circumflex CTO lesion, so the wire and the balloon will cross over the proximal lesion of the bifurcation lesion. We don't want to touch the proximal bifurcation lesion before we perform PCI for this lesion. So even though we want to use a wire, we want to use a microcatheter to support crossover the lesion.
This is the circumflex and the OM1 bifurcation. And here at this point, the area is just 1.8 millimeter square, and the plaque burden is more than 80%. Then go and pull back, we can see calcified plaque, and the calcification angle is about 180 degrees. Okay, this is the baseline IVUS imaging.
So after successfully cannulate distal CTO and the predilation, so I will show actually distal and the OM2 is also true bifurcation, although it's a simple bifurcation according to the definition criteria. But from the IVUS imaging, maybe distal vessel capillary is a little larger than the OM2. So Dr. Ye, what's your strategy for this typical simple bifurcation lesions?
It's very difficult for me to treat this bifurcation lesion with a very small distal side branch and main branch. From the IVUS, we can see the distal circumflex was 2.3 reference diameter, but for OM2 only 2.2. So we want to stand in a larger branch.
Yeah, now let's go to today's target for this circumflex and OM. Very difficult to access, very wide angle, and also severe narrowing at the bifurcation site. So I think for this scenario, I think first is we should successfully wire the OM1. So routinely, I think for this very wide angle, we will use dual lumen cassette for facilitate the wiring. And also the wire shape of the angle is very, very important. So Dr. Ye, can you introduce a procedure?
The angulation was very, very sharp, over 90 degree. And the bifurcation side was very stenosis at the main vessel. That means main vessel black bottom was very high at the bifurcation core. And another question is how to select the first wire. First wire is very important for me to, I want to choose, so the talkability was very good. And the tip of the wire was keep the shape was very, very stiffly and stably. And another question, another wire is hydrophilic wire is maybe the best choice, but we can not get a good support from the wire. And for me, first wire I want to choose runs to extra soft. If the wire failed, so another is a cyan blue or cyan blue may be better just because the tip of the wire was softer compared with cyan. Another, if still failed, so XT or XTR was the third choice. If still failed, and I will select a hard wire. But there is some information from the IVUS can tell me how to select the wire. I will show you the how to shape the wire.
New one, run through.
We also use
Double curve. Double curve.
Just because the bifurcation side was very stenosis, so the length of the tip was very, very short. I show you how to shape with transducer. Could you zoom it?
Yeah. Zoom in.
Yeah. 看不太清楚。
再放大。
No. You talk the wire, Dr. Chen Liang, please. Talk.
旋转.
Yes. So with a double curve of the workhorse wire and a very short length. Yes. Okay. After that, we should use a double channel catheter or micro catheter to select, so to negotiate the osteos when. So first, we use a micro catheter just because the micro catheter was on the table before we treat the distal CTO lesion.
Okay.
So next, we cannot push the wire, just talk, just run. Make sure, okay, you can find the wire tip in the OM easily.
Yeah, excellent technique.
So if this procedure failed, we can select another kind of wire with the same shape of the wire. If still failed, we can use a smaller balloon to pre-dilate the main vessel to make sure, just like the massage for the main vessel plaque, so we can make the space of the main vessel larger, so the wire in the circumflex may be a little easier. If still failed, what should you do next?
I think if still failed, I think next step is very important because the significant narrowing of the osteomer diagonal. So we will change the wire, maybe a stiff wire like a Gaia one, still with a double curve shape. Very cautious manipulated wire tip. Try to successful wire the side branch. According to the definition criteria, the angio results show simple bifurcation, and the IVUS also show very, very focused short lesion just at the osteomer margin.
Yes.
After 2 balloon predilation.
Yes.
What's your strategy?
So one stand tactic to just use provisional.
Okay, I agree with
So I recheck the IVUS for the main vessel again to show the distal part of the stand and the proximal stand landing zoom to select the proximal stand size. This is a 225 stand.
The stand mean diameter is over 2.5.
2.5.
Yeah.
Vessel size is larger, yeah.
So I think maybe next we use a large balloon to post dilation at the first instant, just before the bifurcation side.
Yeah, yeah.
So just because the angulation between the OM and the circumflex was very sharp and wiring was so difficult.
Will you?
How
Yeah.
to protect the
How to
OM?
protect?
Yes.
The very important technical
Check the angle.
issues.
So after wiring, we want to check the angulation between the OM and
it's smaller.
Yes, it's smaller.
Yeah, you will use a gelled wire or you will aggressively use a gelled balloon?
Yes, it's a very challenging. For me, safely, I want to use gelled balloon. It's safer.
Yeah.
So give me 35.
26.
3526.
Yeah.
From the
from the proximal circumflex to the
balloon.
to distal
gelled
balloon.
balloon.
Yeah.
多大的？
202 balloon.
200。
How to select the gelled balloon size, Dr. Ye?
Yes, and according to the I was finding the proximal pattern maybe 2.5 is a reference diameter. Sometimes I want to downsize gelled balloon wide, gelled balloon size. This is to stand first. So for gelled balloon technique, standing first, then balloon second.
Okay.
Okay.
Nice.
If we find the osteo OM was compressed, we can perform the kissing in or out.
Okay.
Sometimes just because the stand. Okay, inflection. 6. Yes. After that, we pull back the gelled balloon. Okay. Stop. We can find the guiding castle was very stable without push into the left coronary artery. So there's the chance of the destroyer of the osteos left main was decreased. So we pull back the 3.5 balloon. So inflation first, 6 atmosphere. Yes, 6. Just leave it. Okay, keep it maintained for 30 atmosphere. Okay, flow is good
without dissection.
So we want to pull back the gelled balloon.
Yeah.
Push the 3.5 balloon a little distally. Okay, inflation 6. That's enough. Pull back the gelled balloon. Okay, stop.
Nice.
Stop.
So after you pull out the gelled balloon, maybe the proximal stent segment will be deformation. So you will use a 3.5 to do the post dilation for the proximal stent segment.
Yes. So first is 3.5. Another is maybe a big one.
Yeah, for all, yeah.
After that, we check the flow. If flow is okay, we will pull back the wire. Okay.
Nice.
Okay. Inflection. Hunter, could you show me the proximal circumflex reference diameter?
For all, at least.
This point is the proximal. 3.8.
3.8.
Lumen diameter. Yeah.
Lumen diameter. Okay.
The port is very important. Just as Dr. Ye mentioned, we should avoid the distal edge of the port balloon extending the carina. Otherwise, we will cause the carina shift again. Yeah. Especially for this very difficult access the wide angle bifurcation.
Now the back test. Okay. I think port is very important. Okay. To use a special port balloon. Second, not second.
The distal cell.
The
Okay.
distal cell.
Okay. So this is actually extremely younger patient. So why triple vessel disease? So for this patient, what's the risk factor?
Hypertension and smoking.
Smoking,
Yeah, too much smoking. He's a heavy smoker, I think. Okay. Quit smoking is very important.
Okay.
Small dissection.
Yes. I think I need a small dissection. No, okay.
Yeah. Just at the stage, yeah.
Maybe we should put another small stent.
Yeah.
Depending on the if there is a landing zone.
Okay.
No,
Okay.
diffuse lesion in the distal.
That means a distal. If there is low and suitable landing zone, just
Timmy flow is good.
yes, just pre-dilate for a long time. That's enough.
Yeah, yeah. Long-term inflation. Yeah.
Yeah,
It's a
yeah.
small vessel. Yeah.
Yes, then the expansion was very good.
Yeah.
Okay. Yeah.
It's a proximal circumflex.
Yes.
Stand mean diameter more than 3.0.
Yes. Just below the first bifurcation lesion, I think. You cannot see the OM1. It's not coming.
Not find it.
Yes.
Yeah. One moment, maybe it's coming now.
Yes, I think so.
This is OM.
Yes.
Yeah, we can see
yeah.
the.
I think the Austrian is quite good.
Good.
It's I think this bifurcation lesion, I mean the proximal circumflex bifurcation is very, very good evidence for depletion criteria. Even from the Medina classification 111, we should use a 2-stent technique, but for the length of the segment was shorter than 5 millimeter. So I think 1 stent is
enough.
Yes, it's a very, very good result after my method standing. We don't need 2-stent to treat this kind of situation. Would you see any of the proximal part of the circumflex is good? It's a diffuse lesion.
It's also
Okay.
okay.
We can measure the distal part and the
The
proximal
distal
part.
stand age, we can find the medial dissection.
Yes, you can see it.
The
and
lens.
find the hematoma. And wait.
Give me 2 balloon. 2 balloon.
Here, hematoma.
220. 22. Yes. Could you show me the distal part, the normal part?
Is there any landing zone of the distal cell?
Yeah.
No.
The distal
too small.
Very small.
Too small. Too small.
Yeah.
Maybe we can do the long-term inflation and check angio again. Yeah.
But Timmy flow is okay.
Timmy flow. Could you show me the distal part standard age to the normal part of the distal circumflex? The lens.
The lens.
Wait.
This is actually.
Maybe here.
No, more
15. Yes.
More than 15.
More than 15. Okay.
But the distal is not normal.
Yes. I use.
And the vessel is not more than 2.0.
That's enough. That's enough.
Yeah.
balloon is enough.
I just push. No.
So I think the stand.
No. Okay, enough.
6.
No. 4. 4.
That's good.
Enough.
I think for the distal flow is quite important because the longer stem from the proximal to distal cell.
Yes.
Yeah, we should keep at least the TMC flow and the radial stenosis less than I think 30%.
Yes. If there is a low hematoma, low dissection, there is low severe stenosis, we also can use a small drug-coated balloon to treat it. But flow is a most key point. That means most important issue. So could you measure the standard expansion in the distal and the proximal part and the middle part?
For the proximal landing zone is optimal, less than 55% blood burden. 53, yeah.